Now we're going to talk about the main things that separate or differentiate the different types of dialysis. Number one, we're going to talk about dialysis access. So first, intermittent hemodialysis. Remember, this is hemodialysis done every other day or so, 3 times a week. And so here are the main forms of access. As you can imagine, you need access to the blood. And so first, you can do it through a artificial catheter, the dialysis catheter. This could be either a temporary catheter, which is non-tunneled under the skin, or what we call the perm cath or permanent catheter, which is tunneled under the skin. Okay. The main problem is that these are prone to bloodstream infection, and so it is recommended to not have a permanent catheter or try to minimize use of a permanent catheter, but instead use what we call a more permanent vascular access, the AV fistula, arteriovenous fistula, or the arteriovenous graft. And these two require surgical placement. Usually a vascular surgeon or an interventional nephrologist can do this. The permanent catheter is usually placed by either an interventional nephrologist or interventional radiology. And then the temporary catheter can be placed at the bedside, typically by a nephrologist, ICU physician, internal medicine physician, interventional radiology, or nearly anyone. For CRRT, remember this is a type of dialysis that requires either hemodialysis or hemofiltration. So again, we need access to the patient's blood, and so this is only done with either a temporary or a permanent catheter. It's not done with a AV fistula or AV graft. Remember, CRRT means it's happening continuously. It's happening 24 hours a day. And so it's not safe for an ICU patient to sit there with needles in their arms like what would be required for the fistula or graft. So it's safest for them to either have a tunneled catheter or a permanent catheter. And finally, peritoneal dialysis requires placement of what we call the peritoneal dialysis catheter. And so this is placed either by a percutaneous method or it needs to be placed laparoscopically by a surgeon. And so the catheter goes through the abdominal wall, it's tunneled under the skin, and then the end of the catheter coils into the pelvis. And so this does require a procedure and a certain amount of time to heal before it can be used appropriately. Okay, this is a very important topic, the complications of dialysis, and it's going to be organized by dialysis modality. So first, let's address hemodialysis. So first, let's talk about the dialysis disequilibrium syndrome. And so this occurs due to cerebral edema or brain swelling. And so why would this happen at the start of a dialysis treatment? So this typically occurs in patients who have been uremic for quite some time and they're initiating dialysis for the very first time. And so this occurs because of urea, essentially. So as you know, urea is considered an ineffective osmol, and that's only because it moves across cell membranes. But it moves slowly. And so imagine if the patient has very high levels of urea that are inside cells and outside of cells. If we rapidly dropped the urea concentration outside of cells and the extracellular fluid, then that slow movement of urea from in to out would actually have a gradient there, resulting in water movement into cells. So transiently, the urea concentration inside cells is so high, water would actually move into cells, and when it moves inside brain cells, it causes cellular swelling. So patients with this develop headache, confusion, worst case scenario, they have a seizure. And so this is something we watch out for in patients who have chronic uremia and are initiating dialysis. And because of this, we can do different things like be very gentle with the first dialysis treatment. So next, consider a filter rupture. Like what if those tubes that were full of blood, if they rupture or break, then blood could actually leak into the dialyzer itself. And now you have direct contact between the dialysate and the patient's blood. And that's not good at all. So filter rupture is a special complication of hemodialysis. Next, the entire filter could clot, actually. And this is why heparin is typically used during hemodialysis. So if the filter clots, not only is dialysis ineffective, it shuts down, and all that blood upstream of the clotted filter would essentially be lost. As dialysis is stopped, the filter is thrown away, and the patient actually loses a lot of blood that way. Also, hypotension can occur. Remember that intermittent hemodialysis is typically done 3 times a week, and so a good amount of ultrafiltration is performed. And so some patients do not tolerate ultrafiltration, And if you have to remove a number of liters of fluid to keep the patient in balance, that can cause hypotension, it can cause cramping or symptoms, and especially can lead to cardiac arrest. And so a lot of our patients have cardiomyopathy, LVH, or they're prone to arrhythmias, shifting of fluid, electrolyte shifts, dialyzing against very low potassium baths or low calcium baths. All these things make it a prime sort of a milieu for cardiac arrest and hypotension. And unfortunately, this happens, and it's a consequence of intermittent hemodialysis. Next, air embolism can occur. So if a large amount of air gets into the tubing, that can go to the heart, and it can cause hypoxemia or worse, cardiac arrest. Also, hemolysis can occur. So imagine the blood is being pumped through a large amount of tubing, and so if there's a kink in the tubing or some sort of mechanical problem, there could be shear stress on red blood cells, and just that alone can cause a significant amount of hemolysis. Or there can be hemolysis due to some sort of contamination of the dialysate water. So water contamination is unique to hemodialysis. That dialysate that I've mentioned in other videos, that is actually mixed on site with ultra pure water that is created on site at the dialysis unit. So you can't just use water that came straight out of the tap. So water out of the tap contains chlorine or chloramines that was used to purify the water, right? The city does that. But in order to actually administer dialysate water, remember that's going to be in very close contact with your blood, and you don't want bacteria or endotoxins or other heavy metals or chlorine in that water. And so on site, dialysis units have to make their own ultra pure water that's now safe to be used as dialysate. Okay? And so if somehow the water purification system is down or there's a problem, contamination of the water could make the patient sick. And so the biggest risks are heavy metal intoxications or chloramines, which are added to city water. Also, patients can have allergic reactions to different dialyzers. In the past, some of the dialyzers were more allergenic, and some patients have had anaphylactic reactions. Next, with an AV fistula or an AV graft, remember this is an arterialized system. So it's an artery pumping into something that's draining to the venous system, and so there's a good amount of blood flow there. And so a hemorrhage from either the fistula or the graft could be catastrophic. And so with AV fistulas in particular, an aneurysm could form, and sometimes these can spontaneously rupture. This has happened at home for some patients, and maybe they weren't aware of it. Okay. This could also persist after the dialysis treatment. So after the needles are removed and treatment is finished, the patient can have continued bleeding from their access site. Finally, infections can occur. So there can be infection at the surface of an AV fistula or AV graft that can eventually lead to a bloodstream infection. Or patients who have temporary or permanent dialysis catheters are at risk for bloodstream infections. And this is why AV fistulas or grafts are preferred over catheters because of the lower rate of bloodstream infections. Peritoneal dialysis has its own set of unique complications. So number one is PD-related peritonitis. So as you can imagine, the catheter is a connection between the peritoneal cavity and the outside world. So any accidental contamination of that sterile procedure can introduce bacteria into the peritoneal cavity. And so typically the diagnosis is made by the patient observing cloudy peritoneal fluid. A cell count would show greater than 100 white blood cells per cubed millimeter. And then if you did a differential on those white blood cells, greater than half of them should be polymorphonucleosides. Next, that catheter, as it exits the skin, it can develop a exit site cellulitis. As you can imagine, also outflow failure. So what if you're able to instill fluid into the abdomen, that dialysate, but what if the fluid doesn't drain out? Sometimes just due to nearby omentum or bowel, it can actually form sort of like a one-way valve. And as you can imagine, if fluid goes in but nothing comes out, that's a problem. You won't be able to do your PD anymore. And so it'd have to be fixed mechanically. Also, that catheter, it could leak. So if there's a leak, you can understand that now there's a connection between the outside world and that patient could get peritonitis. Sometimes right after placement of the PD catheter, there could be intestinal perforation. That's obviously something to be aware of. So next is this entity called PD-related hydrothorax. And this is where that dialysate, remember the dialysate is rich in dextrose, it actually migrates across the diaphragm and accumulates in the pleural space, leading to a pleural effusion. And so this could actually be quite symptomatic. And if you can imagine doing a thoracentesis, that fluid would actually be very high in glucose, and that's one way you could make that diagnosis. Next is this entity called encapsulating peritoneal sclerosis, and we're not really sure why this occurs, but it appears to be a sequence of peritoneal inflammation, which leads to fibrosis and unfortunately bowel obstruction, because the entire peritoneum sort of starts sticking together and the bowels get stuck together, and it's a quite devastating diagnosis to occur, and it occurs in PD patients sometimes. Next, some patients develop chronic fibrosis of the peritoneal membrane, and this actually results in membrane failure. And if the patient is unable to remove fluid off the body, right, by administering high osmotic dialysate, we call that ultrafiltration failure. So for some people, essentially the peritoneal membrane, quote, stops working, basically. So when it stops working, they have to stop doing peritoneal dialysis and switch to something else, like hemodialysis. Also, I've said multiple times that the dialysate typically contains dextrose, and so as you can imagine, dextrose containing fluid actually is absorbed. So some of that dextrose is absorbed and can lead to hyperglycemia. It can exacerbate or cause diabetes, and that could lead to weight gain. And so there is one non-dextrose PD fluid, and it's icodextrin, which is a starch actually, but the majority of PD fluids contain dextrose, and when that happens, weight gain and hyperglycemia can occur. Also, because peritoneal dialysis is very efficient at solute removal via dialysis, there's also convective clearance as you remove fluid, and that actually removes a good amount of albumin, and so patients on PD can typically develop hypoalbuminemia due to loss of albumin in their PD fluid. Last but not least, I want to talk about a few complications that are very specific to CRRT. One of them is bleeding, because as I've mentioned before, we try and prevent filter clotting, and if a patient's on 24-hour dialysis day after day after day, they're typically treated with some kind of anticoagulation, either systemic heparin, or sometimes we do a citrate anticoagulation protocol. But if we're not doing citrate or we're doing anticoagulation, systemic heparin, there is that risk of bleeding, of course. Also, doing continuous 24-hour dialysis, we have to think about drug removal. So if there's a drug that's being administered that's cleared through dialysis or through convection, we have to be aware of that and actually change the dosing. So especially for critically ill patients in ICUs, they're usually getting many antibiotics. Antibiotic dosing typically may have to change once a patient started on CRRT. So always consult with your pharmacist when a patient starts CRRT. Also, with CRRT, we're typically using dialysate and the replacement fluid, and in those two solutions, we're able to adjust the levels of potassium and calcium, but one thing that's not in dialysate or replacement fluid is phosphorus. And so because CRRT is pretty efficient, if you get it working right, we can cause hypophosphatemia in critically ill patients, mainly because they're not taking much in and we're removing so much, and there's no phosphorus in the dialysate or replacement fluid. So you should be aware of hypophosphatemia and checking serum phosphoruses at least daily or maybe every other day to make sure we're not causing profound hypophosphatemia. As you can imagine, that could be really important for a patient on a mechanical ventilator who you're trying to wean off. You don't want a patient to develop severe hypophosphatemia and develop respiratory muscle weakness. So one other thing worth mentioning that's unique to CRRT patients is citrate toxicity. So you'd only see this in patients who are getting regional citrate anticoagulation while they're on CRRT. Remember that when we're doing CRRT, we want to prevent filter clotting, but you may not want to anticoagulate the patient. Remember, I said if you're administering systemic anticoagulation, bleeding is a risk. So to minimize bleeding risk but prevent filter clotting, you can do regional citrate, which is where you administer citrate to the dialysis filter, and that will cause very low calcium in the filter. And since calcium is a necessary cofactor for clotting won't occur. Of course, if we did that, eventually we would make the patient hypocalcemic. So we prevent that by administering IV calcium peripherally. So we administer IV calcium to prevent hypocalcemia, but inside the dialysis filter, there is very low calcium to prevent clotting. However, what if the patient is unable to clear all that citrate? So we do see this in patients with advanced liver disease, end-stage liver disease. There's reduced hepatic clearance of citrate, and that citrate can accumulate. And one way to detect that is through the labs. And so essentially, the total calcium may be normal or high, because total calcium measures ionized calcium plus bound calcium, even if it's bound to albumin or citrate or whatever. So the total calcium may look normal, but if you're not measuring ionized calciums, you may miss it. The ionized calcium may actually be low in the setting of citrate toxicity. And so one rule of thumb is to use the ratio of the two. So total calcium in milligrams per deciliter divided by ionized calcium in millimoles. If that ratio is greater than 10, that does suggest citrate toxicity, and then you should stop it, switch to a different anticoagulation modality.